Hi, this is Claudio Cicerano together with Dr. Persia, Dr. Reichman, Dr. Aldejan, and Dr. Beans. We're presenting to you a case of heart failure or FSGS. Just for background, we're residents from the Cape Coral Hospital in affiliation to Florida State University, and we're highlighting the risk of anchoring bias in diagnosis through this case report. So anchoring bias is defined as a physician focusing on a single initial piece of information in the clinical decision-making process without sufficiently considering subsequent information about the patient's condition. So we really think this case highlights well an important issue that all physicians and especially residents will face. So this is a case of an 85-year-old male with a past medical history of heart failure with preserved ejection fraction, CKD stage 3B and atrial fibrillation that presented with shortness of breath, scrotal swelling, and bilateral lower extremity edema. He was not on any diuretics until about 10 days prior, where he came to the ED with the same symptoms. He had multiple readmissions in the past for this diagnosis of CHF. At that time, he was prescribed Lasix and discharged and came back on our service with worsening symptoms. So a physical exam demonstrated dullness on lower lung fields. We can see here the chest x-ray and bilateral 3+ lower extremity pitting edema. Labs were significant for creatinine 1.73, a BNP of 24,000, which is increased from prior, and this is what really caught our eye there, urinalysis showing new nephrotic range proteinuria and a protein creatinine ratio of 20,000. Chest x-ray revealed cardiomegaly with large right and left pleural effusions, and we did also get a repeat 2D echo showing the same ejection fraction and unchanged diastolic dysfunction of mild to moderate. And we did get diagnostic and therapeutic thoracocentesis, which yielded a transvasative fluid, which is kind of what we were expecting. So in light of these new findings, these multiple readmissions, unresponsiveness to GDMT and oral diuretics, we did get a kidney biopsy, which to our surprise showed epithelial foot process effacement here on electron microscopy, consistent with minimal change disease with underlying FSGS. And here on light microscopy, we can see the segmental sclerosis when comparing to a normal glomerulus. And this patient did also have acute tubular injury. We can see here the tubule sloughing in the intratubular space of these necrosed cells, and on electron microscopy we can see this effacement of the foot processes, and we learned in medical school that minimal change disease is usually a disease of like young adults or children, but it does have a bimodal distribution and can be present in this elderly population, which is what we saw here. So we really took a big learning point from this case, and we compared it to this JAMA article in 2023, which actually took 108,000 patients previously diagnosed with CHF and asked the question, do ED physicians anchor on information found in the patient visit reason section before a physician sees the patient? And we really think we can relate to this as hospitalists and residents kind of do the same when taking handoff for admissions from the ED doc. So it actually found that amongst these patients previously diagnosed with CHF who presented to the ED with shortness of breath, physicians were less likely to test such patients for PE when the patient visit reason mentioned CHF, which was consistent with anchoring bias. And this was kind of the same with this case. This patient had multiple readmissions for CHF, and it was very easy to kind of just throw it off as another CHF exacerbation without kind of looking into the deeper picture with the rest of his labs and urinalysis as well. So it kind of shows the importance of keeping differential diagnosis broad, even if multiple prior visits mention the same principal diagnosis. So, if we kind of overlook the worsening kidney function, the new nephrotic range proteinuria, and the same echocardiographic findings, we could have easily attributed solely to CHF, and the patient would have been just sent home on the same GDMT, most likely an increased dose of oral diuretics, and his underlying problem not being addressed. So by maintaining a broad differential diagnosis, we were able to identify the true etiology, which was FSGS with minimal change disease. And as a result, the patient was started on proper immunosuppressive therapy with tacrolimus and addressing the underlying renal pathology. So we would just like to thank Arcana Laboratories for sending the specimen from this patient so we can better visualize these biopsy samples. And I want to thank you for listening to our presentation on heart failure or FSGS.